Hope you're all doing well. We are glad to have our session today. This is our 7th session of the Oxygen Therapy and Critical Care, the case-based series. Today, July 29th, 2021. You are all warmly welcome to participate in this another great learning session today. As usual, we are going to have our Hub Director and panelist, Dr. Al-Hassan Datti Mohammed, with us today to lead this session. And also we are going to have 3 co-panelists with us. We are going to have Dr. Henry Embu from Jos University Teaching Hospital in Nigeria. We're also going to have Dr. Hassan Maina Ali from the Federal Medical Center in Yola, Nigeria, and Dr. Mohammed Bashir Rabiu from the Abubakar Tafawa Balewa Teaching Hospital in Bauchi, Nigeria. And also to remind that this session is organized and supported by Assist International, UNM, Eco Institute of Health Sciences, and Aminu Kano Teaching Hospital. So you are warmly welcomed. We are going to have French interpretation available for this session. For those of you who will need French interpretation, there's an icon with an interpretation below, in the line below, as shown. If you have the old version of Zoom, it may not work. You will need a new version. You can choose to mute the English part of the session or listen to both, but the translation will be louder than speak. After sharing this, I would like to welcome Dr. Datti to introduce the panelist and start the session. Thank you. Welcome, Doctor.
Afternoon or good evening, wherever you are, to session 7 of our case-based discussion series. Today we will be talking about defining ARDS, and with me today to guide you through this I have 3 co-panelists. Dr. Henry Embu from the Teaching Hospital is a consultant anesthetist. We also have Mena Ali from the Federal Medical Center, also a consultant anesthetist. And we have Dr. Bashir Mohammed Rabiu from Abubakar Tafawa Balewa University in Bauchi, all in Nigeria, also a consultant analyst. So with that, we'll be asking you to type in the chat box. Instead, that we need to all participate. Change objectives in this session will be we need to define respiratory failure. We use the types of, list the types. Should be able to define hypoxemia using arterial blood gases, arterial blood gas analysis, rather. Then we'll be able to list the 4 key for defining ARDS. We should be able to apply Gali modification to diagnose ARDS. To describe mild, moderate ARDS, and to describe the pathophysiology that occurs in ARDS, and list the principles of lung protective ventilation. And we need to understand which parameters on a mechanical ventilator are for oxygenation in ARDS. To understand which parameters on a mechanical ventilator are CO2 elimination. And we should be able to apply appropriate intervention known to improve oxygenation in ARDS patients. And we should be able to apply appropriate intervention known to improve outcome for patients with ARDS. So this is our case. In part 6 of our discussion, we learn about Mr. T, a 46-year-old man who presented with hypoxemia and respiratory distress. Unfortunately, Mr. T was found to be the SARS-CoV-2 virus, that is COVID-19, and his clinical course progressed to respiratory failure, requiring ICU admission, intubation, and mechanical ventilation. His vital signs and mechanical signs are as follows: heart rate 102 per minute, blood pressure of 97/51 millimeters of mercury, respiratory rate is 35 per minute, 7.5 degrees Celsius, and saturation was 90%. Mechanical ventilator settings are as follows: is on AC mode with a of 100%. Respiratory rate was put at 35, and the entire volume was 400, with a peak of 14 centimeters of water. And then we have a peak inspiratory pressure set at 40. So we look at, I'll call in Dr. Embo, if you can hear me, to guide us through this respiratory physiology and failure. Dr. Embo?
All right, thank you so much, Dr. Datti. And good afternoon once again, everyone. All right, so we're talking about respiratory failure, and I think the first
thing, yeah, we should. Why do we breathe? Let them type in their answer. And see
okay.
Before we click on the results. Thank you.
Yes. So there's a question there. Why do we breathe? So responses are required from the participants. Why do we breathe? Yeah, we're still waiting for responses. Please type your responses in the chat box. We are going to give a few more seconds for responses before we move. Okay, there are still no responses. Okay, they're coming in now. We breathe to take in oxygen and remove carbon dioxide. Very good. So that we can maintain a balance between oxygen and carbon dioxide. Very good. We breathe to maintain the normal concentration of respiratory gases in our body. We breathe for oxygenation, our system. Oh, great. We breathe for gas exchange, cellular respiration, to provide oxygen and get rid of waste gases. So we have quite a number of responses now, which is very good. So can we just move to the resource? We have, yes. So there's this resource on cellular respiration. I think there should be a video. All right. Generally, your responses are good, very good. Most our breathing, why we breathe mostly is for the body to take in oxygen and remove carbon dioxide, which the body does not need. And oxygen generally can be used for cellular metabolism. I think posted on the chat box is the link to the resource you can get for this information, how why we breathe and how gaseous exchange takes place at the alveolar level. Okay. Thank you. Can we progress? This is a short video.
When you breathe in, air enters your nose or mouth
Thank you very much.
and passes into your trachea or
Are we
windpipe.
doing a video?
At the carina, the trachea divides into two bronchi, then branches into smaller bronchioles.
It's not audible.
The bronchioles end in
Not audible. Okay.
Yeah, it's not audible. And then your screen. I think it's difficult to read.
When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea
Is it audible now?
Yes, it's audible. I can hear it from here.
divides into two bronchi, or bronchioles. The bronchioles end in tiny air sacs, or alveoli.
Maybe if we can
Here,
start from the beginning.
oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale.
Thank you. All right. That's a brief video on mechanism behind breathing. So we move. There's another question.
We can't hear you. Don't know whether you're talking.
Respiratory failure is a syndrome rather than a disease. D, respiratory failure usually resolves on its own. And E, respiratory failure may have tachypnea, hypoxemia, and hypercapnia. So we have options A to E. Please, you can type in your options, your answers on the chat box. Which of the following statements about respiratory failure is incorrect? Okay. Responses have started coming in. Okay, responses are coming in. Okay. So far, most of the responses are indicating D, option D. Okay, thank you so much. So far,
I don't know, Henry, you're muted.
all right, sorry. Okay. So far, all the options that came in are indicating D. And D says respiratory failure usually resolves on its own, which is the incorrect option. The other options are correct concerning respiratory failure. So all the other options, A, B, C, and E, are correct, while D is.
Okay, thank you. Again, and we'll continue. Those were great answers, actually, shows the discussion. Now we need to try and list the type of failure. Dr. Hassan may I do this and the Dr. Hassan?
Yes, sir. Okay, good afternoon, sir. So the next question is list the types of respiratory failure. So we are expecting your answers in the chat box, please. 30 seconds. Expecting answers. Okay, we have an answer, acute respiratory failure. More answers. Okay, type 1, type 2, and mixed. More answers. Okay, acute chronic, type 1 and type 2. Okay, chronic. I think we can go to the reference. So from the reference, we have 4 types of respiratory failure. As we can see, the reference that is coming, we have the hypoxic. We go down. Yes, hypoxemic, hypercapnic, 3, postoperative failure, 4, yes. So you can see the classification. The type 1 is termed the hypoxemic respiratory failure. And it uses the partial pressure of oxygen of less than 50 millimeters of mercury. It is oxygen that is used. That is why it is termed hypoxemic. On room air, when the patient is on room air. And like it is said here, it is usually seen in patients with acute pulmonary edema or acute lung injury. These disorders interfere with the lung ability to oxygenate blood as it flows through the pulmonary vasculature. So it is a problem with the lungs or pulmonary edema that prevents oxygen passage into the pulmonary vasculature. The type 2 is the hypercapnic or the ventilatory. So this one is uses the partial pressure of carbon dioxide. And when the partial pressure of carbon dioxide is more than 50 millimeters of mercury, it is termed the hypercapnic respiratory failure or type 2. And this should not be in a patient that is a chronic carbon dioxide retainer. It is usually seen in patients with increased work of breathing due to airflow obstruction or decreased respiratory system compliance, like in patients with muscle problems like myasthenia gravis or Guillain-Barré syndrome, those with decreased respiratory muscle power due to neuromuscular disease. The type 3 is the perioperative. In this article, they showed that the perioperative of the type 3 is also a subtype, considered a subtype of the type 1. It is also hypoxemic, but because it is usually found in the perioperative period, it was classified as a different class, type 3. And the type 4 is the type that is found in shock, which is usually due to cardiovascular instabilities. Can we go back, sir?
Hold on a minute, if I may.
Yes, sir.
Yeah, let's explain something, audience. This classification gives why that statement D in the earlier quiz was incorrect. That it resolves on its own. These are things that you can intervene. For example, one, you can see when you have the long-term ability to oxygenate blood as it flows through the pulmonary vasculature. You can see you can treat or the try to prevent acute lung injury. The type 2, where it is due to obstruction. So you have to try to relieve the obstruction. This can be reversed. And then if you look at type 4, it's a secondary stability. So you need to do something to restore cardiovascular stability that you will be able to treat the respiratory failure. Thank you. Let's go back, and Hassan can carry on.
Yes, sir. So the next question is, what type of respiratory failure does Mr. T have? Can we go back to the introduction on Mr. T, sir? Yes. So they said that he's a 46-year-old man who presented with hypoxemia and respiratory distress. So this explains it all. The first type we said is hypoxemic respiratory failure, or the hypoxemic type. So, and here they said it is hypoxemia. The other parameters have not mentioned, like we see later. So from here, we know that it is a type 1 respiratory failure from the hypoxemia that was mentioned. Thank you, sir. We can go back. We can go downwards. Okay. So the next, should I continue?
Let me just chip in here.
Okay.
If you look at the parameters for Mr. T, it is 100% oxygen, and the output you're getting, the saturation, SPO. So you see there is inability, the gas exchange is impaired. Okay, that's why one. You can see 100% oxygen getting saturation at 90%. So this you should take note of that. So let's go down to the case update. We have a case update of Mr. T, in which the bedside ICU nurse calls the doctor and states that Mr. T from 9 80% to 88% on those parameters. And this is what I'm screenshot of the heart rate, saturation 88, and then blood it's 106/60. End-tidal carbon dioxide is and then respiratory rate of 32. Let's move down and see. So let me call on Bashir to guide us through the next couple on this update of this. Dr. Rabiu? Dr. Rabi, are you with us?
Hello, I can hear you, sir.
Okay.
Yes.
So, seeing the update of Mr. T's, so we would like you to guide us the next couple of questions. Is hypoxemia
Okay,
defined using pulse oximetry?
Yes, sir.
And then
Okay,
you allow type in their answers in 30 seconds before you go to the reference. Thank you.
Okay. The next question we have is, how is hypoxemia defined using pulse oximetry? Then you have 30 seconds to send your answers through the chat box. Then before we take the next discussion.
%, less than 90, 5.
Yes, sir. Can you help me with the answers, because I'm finding some technical challenges to go into the chat box.
Okay. Then less than 95, less than 95.
Okay, I've seen it.
Yeah.
SpO2 less than 95,
Yeah.
SpO2 less than 92. Okay.
I think we can
Okay, sir.
go ahead to see what you.
Okay, sir. So using pulse oximetry, we can define hypoxemia as SpO2 of less than 90%. And once we're able to get this result, with exception occasionally on pregnant women that we define as SpO2 between 92 to 95%. So the next line of action is we have confirmed the presence of hypoxia using the pulse oximetry once the saturation is less than 92. And the line of management, we should commence or start oxygen therapy, either using one of the available devices in our facility, either nasal cannula, nasal prongs, nasal catheter, or pacemask. Usually, it's recommended to use nasal prongs in less than 5 years, children that are less than 5 years. And it's important to know that we need to keep a pacemask on the patient over the nasal prongs and also under the other devices such as the oxygen mask. This may reduce the virus spread to staff. on the patients. It's also we should notice that the target SpO2 is greater than 90%, but occasionally we find it difficult to achieve in suspected case of in some cases. And once it's continued to be less than 90 despite the oxygen therapy, then we begin to suspect acute respiratory distress syndrome. Therefore, we can consider other options to improve oxygenation, like proning of the patient using pillow under the chest. This may help to minimize the need for mechanical ventilation. However, if the SpO2 does not improve despite proning or simple proning, then it means advanced oxygen therapy and using non-breathing masks, using CPAP or mechanical ventilation may be required. And with this indication, it means that the patient cannot continue to be managed in the general wards. They have to be moved to either high dependency unit or intensive care units, where they can be intubated and placed on mechanical ventilation.
Right. Thank you, Dr. Ravi. Let me just say something here. First of all, the link to this great resource has there. You take note of it. Ravi is trying to explain when you have a patient in your have facilities to ventilate the patient, you have to commence, once you confirm hypoxia with the pulse oximeter, you have to start oxygen therapy with the available resources you have, the devices you have. And maybe I should remind you that this patient, if you have a patient like Mr. T who tested positive for SARS-CoV-2, when you are giving oxygen, you want to consider putting a face mask, a mask over just to minimize risk of contracting the disease. You need to protect yourself. So let's go back about proning. I think we will come to that later and explain further. Have you something about arterial?
Yes, yes. So the next question is, how is hypoxemia defined using arterial blood gas analysis? 30 seconds to send your answers into the chat box. Thank you. AVG less than 60. Well, the parameter has not been mentioned, but is a fair attempt. Arterial partial pressure of oxygen less than 60 millimeter of mercury.
Not 60.
Yeah.
I think you can put the reference,
Okay, sir.
what we have.
Um,
So to get information on to analyze or how to do arterial blood gas analysis, you have this great reference. Check the link has been uh, sent to the chat box.
okay.
Not all facilities will have uh, luxury of doing arterial blood gas analysis. It's a great resource that can guide you. You can see these results, reporting, and critical findings. First, you have to consider the pH, also the partial pressure of oxygen, and then the partial pressure of carbon dioxide, and then the bicarbonate. Then you will be able to analyze and say whether this is a respiratory acidosis or respiratory or mix. So this is a great resource that you rely on if you have the facility.
Okay, I'm back, sir. Can I continue?
Sorry, I knew you were off. Okay.
I can hear you now, sir.
Yes. I was just explaining this is a great reference that they can use to help them in the blood gas analysis.
Yes, sir. As the normal range of the parameters.
Yes, almost everything can be found here to guide, but
Yes.
not all facilities have blood gas analyzer.
Yes.
But that is why we can also use the pulse oximetry as you earlier explained.
Yes, sir.
So if you look at this great example here of a patient with a pH of 7.39, PaCO2 of 51 millimeters of mercury, and PaO2 of 59 millimeters of mercury, and bicarbonate was 30 milliequivalent per liter, and then the saturation at 90%, just like what we have on Mr. T. So pH is in the normal range. So for this one, because it's 7.35 to 7.40, so it is at the cutoff point, in which case it is less than 7.4 acidosis is present. So in this case, this one is okay. Then the PaCO2 is elevated. 30 milliequivalent is elevated, and then that means it's indicating a metabolic process, metabolic alkalosis. And then the value is consistent with the pH. The value consistent with the pH is the PaCO2. Therefore, this is a primary respiratory acidosis in this example. So the acid base that is inconsistent with the pH is the bicarbonate, as it is elevated. So last, the PaO2 is decreased, indicating an abnormality with oxygenation, just like we've seen with Mr. T. But a history and physical examination will delineate the severity and urgency of the required intervention. So you have examples here to rely and practice how to interpret arterial blood gas analysis. Let's go back to the main presentation. Now, thank you, Dr. Rabiu. Now, defining ARDS. We need to know what is ARDS in the first place. So we have some questions also to remind us, having gone through all these keys, so that we can revise what we know and see what we can practice. Dr. Embu, if you're around, can you guide us through this one, please?
All right. Thank you, Dr. Datti. So to our participants, once again, there's a question on the board. What do the letters ARDS stand for? A is adult respiratory distress syndrome. B, adult respiratory disease symptoms. C, acute respiratory disease sickness. And D, acute respiratory distress. You'll just type in your responses on the chat. So far, the responses that we did. Okay. Okay, somebody said A. All right, D. So, very good. I think most of the responses are D. Thank you so much. I think, and the ARDS actually stands for acute respiratory distress syndrome. So the option D is the correct option, which almost everybody got. So that is good. Very good. So can we move on to the next question? The next question says, list the 4 components outlined in the Berlin definition of ARDS. List the 4 components outlined in the Berlin definition of ARDS. So we'll be expecting responses for this question too. The 4 components of ARDS as listed in the Berlin definition. So we take a few seconds for your responses. So far, I cannot see any responses on this question on the chat box. All right. Okay, there's one. Set onset 7 days of defined cause, cardiogenic pulmonary edema. Okay. Okay. I think we'll just go to our resources. Can we just click on the resource and see what? All right. So we have here on the clinical diagnosis Berlin definition of Berlin definition. So yeah, can we can we scroll down a bit? Meanwhile, the link to this resource will be available to you on the chat box. So can we scroll down just to get at, yeah.
Yeah, that's the Berlin.
Yes, very good. This is the Berlin definition. So one is that respiratory symptoms must have begun within 1 week of a known clinical insult, or the patient must have new or worsening symptoms during the past week. 2 is that bilateral opacities must be present on a chest radiograph or CT scan. These opacities opacities must not be fully explained by pleural effusion, lobar collapse, lung collapse, or pulmonary nodules. And 3, the patient's respiratory failure must not be fully explained by cardiac failure or fluid overload. An objective assessment, for example, echocardiography to exclude hydrostatic pulmonary edema is required if no risk factors for ARDS are present. And number 4, a moderate to severe impairment of oxygenation must be present as defined by the ratio of arterial oxygen tension fraction to fraction of oxygen inspired oxygen. That's partial pressure of oxygen, arterial oxygen to fraction of inspired oxygen, the ratio. And we'll come back to that later, but we can see like our patient has a severe hypoxemia by an arterial partial pressure of less than 60 milliliters of mercury. So this resource has quite a lot other useful information. So I think we'll just go back to the main presentation. All right, good. So that's the link to the resource we just saw, I believe. So the next question. The next question, it says, calculate the P to F ratio. That's if Mr. P has an arterial partial pressure of oxygen equal to 60 and his mechanical ventilator is set to deliver 80% oxygen. What is the P to F ratio? And P to F ratio refers to partial pressure of arterial oxygen and F refers to fractional inspired oxygen. So what is the P to F ratio? So can we have responses on the chat box? The P to F ratio in this patient. Okay. Somebody says, okay, P to F ratio less than 300 with PEEP. Okay. All right. Responses are coming for that. Somebody has responded with 75. 75. Okay, 100. 100. 2 people responded 75, 100. And if we say 60 over, if it's 80% oxygen, that is an FiO2 of 0.8. So it's 60 over 0.8, which is likely to give us 75. So 75 is the P to F ratio, is a correct ratio for Mr. T. So the next question is determine if Mr. T, yes.
Sorry, Embo, I think let's not miss out on this reference on this PF ratio.
Okay.
What can be useful to the participants?
Yeah, yes, this reference. Okay. So I thought we'll take the next questions before we refer to this reference.
Oh, okay. All right.
Yes. So the next question is asking that determine if Mr. T with a P to F ratio we said is 75 has mild, moderate, or severe ARDS. That's the question. So can we type our responses? Okay, responses are coming already. Somebody said severe ARDS. So remember the P to F ratio is 75 as we calculated. Okay, somebody says severe ARDS P to F ratio less than 100. Okay. P to F ratio, okay. Severe. All right. So far, all the responses that are coming through are saying severe. Severe. So can we go back to that resource, that reference again? Okay. Okay, let's scroll down a little. All right, so we can see definitions of mild, moderate, and severe ARDS using the PF ratio. It says mild ARDS, the partial pressure of arterial oxygen over the fractional expired oxygen is greater than 200 millimeters of mercury on ventilator settings that include positive end expiratory pressure or continuous positive airway pressure, CPAP, of greater than 5 centimeters of water. Moderate ARDS, the partial pressure of arterial oxygen over the FiO2 is more than 100 milliliters of mercury, but less than or equal to 200 milliliters of mercury on ventilator settings that include PEEP of greater than 5 centimeters of water. And severe ARDS, the PaO2 over the FiO2 is less than or equal to 100 milliliters of mercury on ventilator settings that include a PEEP of greater or equal to 5 centimeters of water. So from this definition and from our calculation, we know that Mr. T had a PF ratio of 75, which is less than 100 milliliters of mercury. So his ARDS can be categorized as severe ARDS. So can we go back? Thank you. The next question says, can ARDS be diagnosed when arterial blood gases are not available? And this is a very good question because there are many ICUs that may not have arterial blood gas analyzers. So is it possible to diagnose ARDS when arterial blood gases are not available? So you could still type your answers on the chat box. Okay. Yes, yes. Some are okay. So far, the responses are saying yes. Okay, somebody said no, but we can suspect ARDS. Okay. Yes. Okay. All right. So there's a reference to that question, which can help us to answer this question. Okay. Good. I think this is, if we can scroll down, maybe we can get to. Okay. This is not really what, this is not actually the reference I want. Can we? Okay. Well, actually, it's possible.
Is the one.
Sorry?
Yeah, I just want the Berlin criteria for ARDS on availability of blood, which you pointed out, resource limited settings, be feasible. That is what. So now that is a modification of the Berlin to person to diagnose the I think this is the reference.
Yes, yes, quite right. This is the reference. Yes, it's a modification of the Berlin reference definition, sorry. So it's the Kigali modification of Berlin definition. And yes, if we scroll down, we'll see that they utilized oxygen SpO2. Yeah, okay. It's a fraction of peripheral FiO2 as a definition for ARDS in this case. So instead of using arterial oxygen, partial pressure of arterial oxygen, this time the peripheral oxygen saturation over FiO2 was used in this case to define ARDS. So it's a very good study and article, and you'll find a lot of useful resources there. All right, thank you. So I'm sure the link too will be available for this resource on the chat box.
Thank you very much, taking us through to understand how to ideas, both in settings where you have tools such as the blood with the Berlin criteria. The one is modification criteria which you can globally. You don't need the blood, which is expensive to purchase and also to manage. Remind you still RDS diagnosis. Remember that it's exclusion. Exclude causes that can pre-oxygenation or cardiogenic.
Dr. Datti, I think you're breaking a little bit. We can't hear you clearly. Maybe you can try also stopping your video if the network is not very good.
Okay, thank you. What I'm trying to say is that in the Berlin for diagnosis ARD, it's stated that diagnosis of you need to exclude that pulmonary ischemic edema. Now apply those because ARD into pulmonary because the pathology at the alveolar. Okay, very much. Let us let's see. Go to the update. So now to having after to diagnose RDS, understand the pathologic changes occur during Dr. Ahmed review. Tell us about this and have to say guide us in.
Okay, thank you, sir. For the participant, we should list at least 3 physiological changes that occur in the lungs during ARDS. So you can send your answers in the chat box.
Yeah. Just these 3 pathophysiologic changes that occur.
Yes, I'm yet to see any
So perhaps you lead them to the reference and let's go through this together.
Okay, yes, because I can't see any response now. Okay, basically there are three, before we get the reference ready, there are three basic fundamental changes that occur in the lungs in the process of disease progression to ARDS. In summary, we have three phases. Phase one is called the exudative phase. Then we have the second phase, which is proliferative phase. Then we have the last stage, which we call fibrotic phase. That is a phase of where the scarring activities and fibrosis take place. In a simple term, in the first phase, that is the exudative phase, basically is considered to be as stage where there is diffuse alveolar damage and it's associated with fluid occupying the alveoli, thereby interfering with the gas exchange across the interstitium into the capillary. Then during this process, there's a lot of inflammatory changes, a lot of immune reaction to that flooded areas. Then this inflammatory response, we all know, is capable of causing some endothelial damage and also the epithelial cells in the alveoli. And there is also the inflammatory markers we know that are released, which can cause increase in permeability in the capillary, leading to more fluid being exudated into outside outside from the capillary, pulmonary capillary into the interstitial space. Then we knew that from the basic knowledge that there's a surfactant which is responsible for keeping the interface of those alveoli, protecting them from collapsing. So those inflammatory changes also lead to the destruction of type 2 cells that release those surfactants and also destroyed the ones that were also released, resulting in collapsing of those small alveoli through a process that we call atelectasis. Similarly, some other changes, those exudative fluid may lead to microthrombosis along the pulmonary capillaries. Then when these changes happen, the next stage that occur is proliferative changes, which a situation whereby that exudative fluid is now slowly reabsorbed through the lymphatic system. And then those epithelial tissues now regenerate, they proliferate and differentiate. And there is also decrease in permeability, as we discussed in the first stage, which is associated with increased permeability. So in this stage, that permeability that results in more of the exudative fluid into the interstitial space is also reduced or restored. Then the final stage, after this stage that look like a stage of repair to restore the normal function of the capillary and the alveoli, then the next stage is fibrotic stage. And this fibrosis is usually associated with second stage, which is associated with exaggerated proliferation of those alveoli and the capillaries. In this stage, basically what happens is that there is interstitial fibrosis and also there is vascular fibrosis. These changes lead to decrease in compliance of the lungs, increase in pulmonary pressure, resulting in pulmonary hypertension. And these changes could explain the classical features we've seen in these conditions that is known as ARDS.
Yeah. Let me just say that the summary here, this article, you can see the ARDS present as hypoxia, and then you get the bilateral pulmonary infiltrates, which is the hallmark of what just Dr. Bashir described when you do a chest imaging. And all this will have to be in the absence of heart failure, sufficient to account for this clinical state, just like what the clinical state of Mr. T. And management, we should know that is largely supportive and is focused on protective mechanical ventilation, which hopefully we'll see later on, and then the avoidance of fluid overload. These are the two things that we need to focus on when we are managing them. Patients with severe hypoxemia can be managed with early short-term use of neuromuscular blockade, prone positioning that was mentioned, prone position ventilation, or you can use extracorporeal membrane oxygenation. And the mortality is significant, up to 30%. Okay, let's go back to the main discussion. So I think there is a video we need to see before we proceed to understand this properly. Let's see the video. But it's not audible.
There is no audio for this video.
Yeah, no. Oh, okay, no audio. All right. So let's watch it.
So we can see in the early stage when there is exudative changes, there will be inflammatory process and swelling of the alveoli, and there's increase in interstitial fluid that is due to the increase in permeability in the pulmonary capillary. Then in the proliferative stage, there is increase in regeneration of the alveoli, and also there is increase in neovascularization. There's excessive alveolar in the capillary, which in the fibrotic in scarring of the tissue, decrease in capillary compliance, alveolar compliance, resulting in overall decreased lung compliance and interference with gaseous exchange, which provide the hallmark of hypoxia that we've seen in this clinical condition.
Okay. Thank you very much, Dr. Bashir. Now, you can see the useful resource that you can get often criticalcare.org. Click there, you see to take you to the resource there to understand more on the ARDS. Now we go to the mechanical ventilation when you are treating the ARDS. Scroll down. So, so we need to now be able to define and can now discuss the goals of each of the following parameters of mechanical ventilation. we need to see how do you use tidal volume, the FiO2, and then plateau pressure, and then P, and then the driving pressure. Dr. Hassan, can you guide us through this to just simplify for our participants to understand this? Hello, Dr. Hassan. Okay, maybe Hassan is not. Hello, Hassan. Okay, Kevin, let's click on the reference. Let's see. So the reference have is often critical care. First of all, you need your ventilator, you need the driving, because you need to have access to oxygen, compressed oxygen, and compressed air to drive your ventilator. These are the tools or the equipment that you use. Let's scroll down. I want to see where these are discussed, the tidal volume, the protective ventilation. Okay, let's go back. Let's go back to the minutes.
So can I go on?
Yeah, okay. Bashir, you have something to say.
Yes. So the protective lung ventilation. So we all know that the tidal volume is the basic simple amount of the air we deliver to the lungs, either we breathe in and the one we exhale out. So if you're setting a mechanical ventilation for this group of patients, it is important to remember the basic pathology we just discussed on, that there is fibrosis, there is decrease in the lung compliance, and all sort of things. So you need to reduce the amount, or you need to reduce the amount of tidal volume you take into the lung due to decrease in that compliance, while you are aiming to maintain the same unit ventilation for that particular patient. So how you do that is you now reduce the tidal volume in your setting with a target of 4 to 6 mils per kg. So in these circumstances, okay, additionally, there may be a group of patients that you need to make an adjustment. For example, in a patient that is on tidal volume of 6 and you are unable to achieve the target SpO2 greater than 90, you may still need to, and you are having
Sorry, Dr. Bashir. Okay, Dr. Bashir, you're not audible. Okay, we are running out of time. We need to quickly go down to see the other areas of management. Let's go down. Sorry, Dr. Bashir. When you're back, we will. One of the things also you need to know is that you need to consider paralysis. You need to know whether it has any advantage, or you have to know the disadvantage of neuromuscular blockade when you are ventilating patients with ARDS. And let's click on the reference to see the post because we're running out of time. Again, this will take you to Open Critical Care, the source. And I think in the initial phase you can paralyze, but it is not widely practiced. So, the references you can get to understand the benefit of neuromuscular blockade. You have to use it early for about 48 hours. That is the conclusion. So it is not advocated for long time management of severe ARDS. Let's go down. Now, one of the key areas of management is fluid management. Remember, I said that you need to avoid fluid overload in ARDS. So the question here is that should we aim for liberal or conservative strategies? Let's click on the reference. The reference is trying to throw more light on the two fluid management strategies of acute lung injury, which is part of ARDS. Now, findings here, let me just go to the findings, the conclusion here. The conclusion was that no significant difference in the primary outcome of 60-day mortality. The conservative strategy of fluid management improved lung function and shortened the duration of mechanical ventilation. So it's not, what it's saying is that it's better to avoid liberal. You need to control the fluid management tightly. Back to the test discussion, please. So, and these are the references that you can do. Now, the prone positioning. Now, Dr. Bashir, if you're back, you wanted to talk about prone positioning early. Bashir, are you back? Okay, Dr. Hassan.
Yes, sir.
So please quickly talk about our prone positioning. We have just a couple of minutes left.
Okay. So the prone positioning was is also a modality for treatment of ARDS. Can you press the resource, sir? These are the questions. When should it be used, in which patients, and how is it done? So this resource is an article that showed a trial, crossover trial it is called, was conducted in 466 patients, which were followed up for 28 days. And some criteria were met for all the patients before the prone positioning was tried. And patients were put on prone position for 16 hours and then were turned to supine. And it was applied for up to 28 days. So, and this prompt positioning was showed in that trial to decrease the 28-day and the 90-day mortality. So it is a very important modality in treatment of ARDS. Thank you very much.
Thank you very much. I think in the result, there is even a video on how to do that. You can watch it at your convenience to see how it is done.
Should we watch the video or should we just go on?
Let's go on because we don't have time. I think once they get to the result, they can view the video. So then also you have to use, the issue of pulmonary vasodilators. There's a question here. There is ample evidence that inhaled pulmonary vasodilators, such as inhaled nitric oxide and inhaled prostacyclin, improve mortality in ARDS. This is also, there's a lot of controversy here, whether nitric oxide is a friend or an enemy or a foe. Let's go down because this was supposed to be a small group breakout session, which we don't intend to. Now the case conclusion here, but we're running out of time. Mr. T has been in the ICU under your care for 10 days and he was placed on mechanical ventilation and dexamethasone. He received neuromuscular blocking agents and underwent intermittent prone positioning according to protocol for 5 days. He was also placed on inhaled prostacyclin. His fluid balance was kept negative using intermittent diuretic medications. On day 8, his oxygenation began to improve. His FiO2 and PEEP requirements decreased, which is what we desire, and he remained hemodynamically stable. On day 10, you are now considering sedation, weaning of the mechanical ventilator, and soon a spontaneous breathing trial in hopes of extubation. Let's scroll down. These are just those. So what we're saying that with all these strategies, Mr. T appeared to have improved and then on its way out of the ICU. Now, in summary, we try to, it's a very long topic that one session cannot address all, but we try to define what is respiratory failure, list the types of respiratory failure, define hypoxemia using pulse oximetry, define hypoxemia using arterial blood gas analysis. And then where you don't have this facility, you can apply the Kigali multiplication to diagnose ARDS. We try to describe mild, moderate, and severe ARDS, understand which parameters on a mechanical ventilator are adjusted in protective ventilation and prompt positioning. So I leave you with this quote. If you want to lift yourself up, lift up someone else. I want to thank Dr. Hassan, Dr. Embo, and Dr. Bashir for giving us their time to be the co-panelists on this session. Thank you very much. And thank you to all the participants. Remember, you can go to the Garden Resource Center to get all this thing over and over again. I'll hand you over to Kevin, Emphasis International. Thank you. Kevin, closing remarks?
Yes, thank you. Thank you so much, Dr. Datti and the panelists. We have reached the end of our session. Thank you for the long session. We apologize for the issues of internet instabilities that we had during this session. We will try our best to fix those in the coming session. So you can visit the Learning Resource Center for the presentation slides and recordings. The site also, as you've seen, includes many additional resources, quizzes, case exercises, and videos. And this is the link. And also the link for the recording of this session in the Learning Resource Center will be shared after this session by email. You can join our community WhatsApp group by scanning this QR code here, or you can message assist at this number. We thank you so much for joining this session, and we would like to ask you to please join our coming session, session 8, which will be held on the 26th of August 2021. And we will be discussing high flow nasal cannula and non-invasive ventilation. If you have any questions, please email us at echo@assistinternational.org. Thank you so much for joining, and see you next month.
Thank you everyone for the great presentation. I'm just closing now. Thank you everyone.
Yes. Thank you, Unish.
Thank you so much.